A long time ago, I circled back and I said that, no, that's enough. We're going to use mirrors. But I was taught to use mirrors by my predecessors. And it's a group of women that were trained by women who understood women's pelvic floors. And it was magical because we gave a mirror to a woman and the first thing she would say is, oh, I don't want to look at that. That's ugly. I said, ugly what? You mean it's like looking at your nose or your pinky finger, right? Is your pinky finger ugly? Oh no, my pinky finger's not ugly. So I'm like, look at the vulva and let's take a look at all the good points here.
Yeah.
And then what I found, and I promise you, I kid you not, 2 minutes into the examination, all of a sudden they're lifting their legs like this. They're trying to reach the mirror like this. They're trying to put it under to make sure that they can see. And everything changed about normalizing what the vulva and anus looks like.
That's incredible.
G'day and welcome to another episode of Endo Untangled. My name is Dr. Alicia Macro. I'm a GP with a special interest in pelvic pain and endometriosis, and I'm joined as always by my lovely co-host, Cherie Noble, accredited exercise physiologist and Grey's Anatomy fan.
Absolutely.
And today we have a very special guest. We're joined by Associate Professor Tanaka Dune, who is a double board certified OBGYN and urogynecologist, both in the States and in Australia. And the reason we've invited her along is to talk about pain in the bladder. So, Tanaka Dune, welcome to the podcast.
Thank you both. This is amazing. And I feel really honored and privileged to be here. So there's nothing more I like to talk about than painful bladder. I love to talk about it all the time. And at least you have one person that you could guaranteed, you send a patient over, I'm happy to talk about it.
Amazing. So important. Any thoughts on being double bird certified?
Well, yes, we
certified.
were talking and my girls are extremely excited that I am talking to a double board certified, just like Addison Montgomery on Grey's Anatomy. They were very, very impressed with your credentials. And like I said, you can walk proud through those corridors of the hospital and be, incredibly talented, as I'm sure you are.
It's a very cool thing because I got to see the whole history of obstetrics and gynecology. Well, I don't know if I can say the whole history, but I got the experience and I got the training. And then subsequently became a urogynecologist. And so back in the day, it was called Female Pelvic Medicine and Reconstructive Surgery, FPMRS. Now it's called URPS, URPS. And because in the United States, with training, you have both urology and gynecology that can become urogynecologist board certified. So when I came to Australia, I went to, it was such a process. It's such a process because there's only maybe 60 of us in the entire country that are board certified urogynecologists. But it's an important process to go through, to be vetted, to know how to do the surgical procedures, and also to take care of the pelvic floor. So I think if there was more of us, it would make access better. That's what I wanted to say. It would make access better. And that comes to training, and the numbers are increasing. And as a urogynecologist and coming from a gynecology background, I'm so privileged to at least understand the natural history of the pelvic floor.
Mm-hmm. And look, I am an absolute huge fan of Grey's Anatomy, and I joke that most of my medical knowledge comes from that show. But all kind of joking aside, I can imagine that extra training has given you a level of knowledge that not people who aren't double board certified have access to. And how has that shaped your practice?
That's really important because you have to think about the original training. And my training in obstetrics and gynecology at Northwestern was fantastic. And this is Northwestern in Chicago. And the training there is 4 years because we typically do about 80 hours a week. And so that's equivalent over here to the training in Australia, which is a few more years, but we also do it in a little bit more concentration. But I have to say that when I became a urogynecology fellow, and urogynecology fellowship is 3 years. When I became a urogynecology fellow, I was like, oh my goodness, what have I been saying to women all this time? Have I been saying, yeah, so your ultrasound looks normal. I can't really see the cause of your problem. Your renal ultrasound and your bladder and kidneys look normal. I really can't see your problem. And in addition to that, I'm personally not sure exactly what the pelvic floor is and how it incorporates into what your symptomatology is. That is not to say that gynecologists do not know what the pelvic floor is, and not at all. But the additional training I received opened my eyes. It was like another chapter. And it was incredible because then I'm like, wait a second. It's invisible in a way, but not invisible. Because for me now it stands out. I can take a look and I'd be like, okay, there's actual pathology that's going on in here. And it's not just determined by the ultrasound, or it's not just determined by the renal ultrasound or the CT scan. The all too famous CT scan.
Tanaka, can you tell us a bit about what a urogynecologist actually does and what their expertise is? I think you've touched on a little bit around the pelvic floor and the bladder and the vulva as well. But yeah, how is it different to a gynecologist and what they do?
Yeah, so a urogynecologist, if you can imagine taking components of urology, taking components of colorectal, taking components of physio, taking components of gynecology, putting that all together, and then understanding the pelvic floor in combination to understanding, I would say, below the kidneys and the upper thigh. But that's also a little bit of a falsehood because you cannot leave out the vulva, you cannot leave out the anus, and you cannot leave out the kinetic chain. And so often, if you see me in my practice, I'll have a patient stand up and I'm like, can you walk from the door to the other end of the room for me? And they look at me like I've got 6 heads. Like, why? No,
Did I walk into the wrong consult?
Yeah,
right?
Like is this an orthopedic consult? Or is it, no. So I'm looking at gait. And I'm also looking at their function. I'm looking also if if they're using anything to help them walk. And so urogynecology is that entire mix put together, serving the pelvic floor. And the pelvic floor, from what I was always taught, the pelvic floor is the floor of your core.
Tanaka, you were telling us off air that your practice and your training went on an unexpected turn when you spent some unplanned time in the pelvic pain clinic of a hospital you were working in. Can you tell us a bit about how you came to know a lot more about pelvic pain?
Yes. And this is the story I can tell y'all. And that y'all came from the fact that I was trained medically. This is my medical degree at Wake Forest, North Carolina. So I never got rid of that y'all. Even though I was born in Zimbabwe, grew up in Canada, I went to medical school in North Carolina and picked up that y'all. So you'll hear y'all every now and then.
Now I'm going to pick up y'all as well. Yeah. By the end of it.
So what happened was, when I decided to do urogynecology, I knew that I wanted to really be a pelvic floor surgeon. I wanted to do reconstructive surgery, and I wanted to help women with their pelvic floors and recovery, and I wanted to connect the body to the pelvic floor. I keep on using the term pelvic floor because I just want to make sure that people understand it's incredibly important and that many things affect it. And I don't know that I completely realized that with my initial training. I knew I'm like, okay, so I can go into urogynecology and learn more about the pelvic floor and become a surgeon. Once I entered fellowship, it was fantastic. I started doing all these surgeries and surgeries and surgeries and surgeries. I'm like, you have prolapse done, fixed. Okay, you have incontinence done, fixed. Next. However, I was taught by some of the best people, and the best people told me, you can't operate on everyone. You have to incorporate the pelvic floor into understanding who you can operate on, when you can operate on them, and what to do if you can't operate on someone. So I was like, I just want to do surgery.
Surgeons want to cut.
Surgeons want to cut. You know? And what ended up happening was and I listen to all the women listening out there. Sometimes the worst things that happen to you is a blessing in disguise. My dad always says that. Sometimes it's a blessing in disguise. And let me elaborate. So I was driving, and I had come out of my car, and I went, without looking, just closed the car door, and my finger got stuck in the car door. So I stood there. And I said, and I know, you crossroads in your life when you start thinking about what am I going to do next? So what happened was, I had the keys in my hand and the car had automatically locked. I didn't feel any pain. I said, if I unlock this door, the pain will come. There's no option. So I went click, unlocked the door, and then I opened the door. Few seconds and then the pain went right to my head. And then I looked at my finger and I said, ooh, the tip of my finger, my middle finger is broken. It's the best x-ray you've ever seen. It's just a middle finger broken at the tip. So I
imagine the worst thing that can happen just about to a surgeon is to seriously damage your hand.
Is to seriously damage your hand.
Yeah.
It was probably a turning point in my life because it was not my whole finger, it was the tip of my finger. And it was an important break. I put a Band-Aid on it and drove home. It was like 5 hours I had to drive home.
Oh, my God.
I know, and slept overnight without doing anything about it. And then this is why I never judge patients ever if they haven't done something, for their health, because I'm right there with you, for many reasons. I went to go and clamp like a scissors or something like that, and I couldn't clamp down. So my consultant, we called them attendings in North America, said, that's
you know that,
it.
I do know that. Yeah, we're talking Grey's Anatomy.
Attendings, same as consultants. Yeah. My consultant said, that's it. You are going to pain clinic. And I was like, oh, I've just been punished. And
there's a movie in that story, I think. There's
I can't believe it. And what am
Shonda's going to pick up this as an episode.
Right, exactly. The other fellows, and it's kind of like that. The other fellows are going to take my surgeries, and what am I going to do? But I had the best co-fellows ever. But I said, what am I going to do? I want to do those cases.
Oh no, and I don't want to go to pain clinic. That's where you don't get to operate on anybody.
And I don't get to operate on anyone. And you have to go, and then you have to go to pain clinic. But it was.
And so, did you know what you were headed to?
Yes and no, because we did pain clinic every now and then.
Yep.
But we had a world leader who was there, who I would say I don't think I truly appreciated who I was sitting next to and who was teaching us. Then I get to pain clinic. And of course, she's a physiatrist, a physical medicine and rehabilitation doctor. And that might be very uniquely North American, a physiatrist. But she's a physiatrist specifically trained on the pelvic floor, dedicated her life to the pelvic floor and understanding the kinetic chain as well and understanding the musculoskeletal system. So I go to the clinic and I'm like, hi, okay, let's start. And she's like, each patient gets X number of time. They get time to talk about their story. They get time to talk about their pain. They get time to review any imaging. And I'm imaging, like what? Okay, so what do you mean by image? Okay, CT scans, their back scans, their x-rays, their bulging discs, endometriosis, anything that comes through to evaluate and how it affects the pelvic floor. And so I said, okay, that's actually kind of cool. And so I was able to talk to the patients at length. I wasn't going anywhere. I had 6 weeks of rest, right? And so it changed my life because the way I thought about pelvic pain was this incurable, nothing you can do state that I felt sorry for patients. So it removed the sorry and removed the pity, and it replaced it with, there are options, there's things we can do, and I will listen to you. That 6 weeks changed my life. And so then I became completely interested in pelvic pain and how to treat it.
That's amazing. And I think number one, that's given me massive goosebumps, which happens not infrequently on this podcast. And number two is that's really why we wanted to do this podcast, is because I feel like, personally, I feel like a lot of the discussion at the moment is around describing the problem, which is obviously a very important thing to do. And it's something that's not been characterised, it's not been acknowledged, it's not been validated by professionals for so long. But I think there is a point where we need to do that. And then we need to start, we need to start thinking about, okay, that's where we're at. Where are we going to go? What are the things that might be going on and how are we going to help someone move forward? Not expecting that someone's going to get better overnight or with a snap of the fingers, but what might be some things that we can start working on in a positive way, bringing our patients along with us to actually help them get better, because that's what we're here for.
Right.
And so that brings us to where I'm hoping to spend most of our time during today's episode, which is talking about the bladder and where the bladder causes pain. And from my experience working with pelvic pain, and yours as well, Cherie, working in the clinic with us, is bladder pain is frequently comes along with other types of pelvic pain.
Yes.
And sometimes it is more almost standalone, although when you look at it, there's often other things going on around it. But it can be a really tricky thing to characterise. It can be a really tricky thing for people to actually get a bit of agency and a bit of lock-in from a practitioner to actually start making their way forward. Because I've certainly seen lots of people with bladder pain bouncing back and forth to different practitioners and different GPs and hospitals, EDs and things. So really looking forward to unpacking that with you, and even just personally taking away some of your tips, but sharing them with our audience as well. But what I wanted to start this episode with is to talk about the bladder in terms of what it is and how it works in the context of the pelvis, because I feel like the bladder is something that we don't apply very much curiosity to. We're all like,
We
yeah,
don't.
that's my bladder hurts.
Yeah.
It doesn't. I got a UTI, whatever. But can you just talk us
And
through?
a lot of people normalize their own bladder habits.
Don't
so
talk
it's
about
either
it.
like they've been, bumped around to different practitioners with problems that they've recognised as a problem. But more often than not, what like I'm seeing, and I think you see as well, is that they don't recognise that it is a problem and it's contributing to the other things that we see with pain and just what's actually what it could be, what it should be like, and what they're experiencing are two different things.
So could you tell us a bit about the bladder, things that you wish more people understood about their bladder, particularly the female bladder, and how it might be different to a male bladder, and how it sort of communicates and is in the context of everything else around it?
Yes, definitely. You know what I like to think about the bladder? I like to think of the bladder as that strong soldier in the back that's responsible for emptying and storage that never should talk to me. If it tells me, hey, I'm a little bit full, just letting you know I'm a little bit more full. Hey, just knocking on the door, just letting you know you may need to go now. You have plenty of time. Relax, take it easy. And you can walk. Hey, now you got to go. Hey, now I will be a problem if you don't go now. But you have time, right?
I'm getting flight attendant vibes from that story. Sometimes letting you know, more insistent, but it can be. Yeah. Anyway, sorry.
We can love that analogy. Nice,
yeah.
But, and that's all it should be. Nice soldier in the back, nice and strong, and can tell you if something's wrong. And sometimes you can get crisscross communication, but I'll talk about that a little bit later. But the bladder basically is to store that urine until it's time to evacuate it. And it's there to get rid of toxins that have built up in the body. And then in addition to that, you want to be able to react and respond to it once it's reached a certain level. And you don't want to react to it before that. You don't want to be irritated by it. You don't want to think about your bladder. It is a privilege that I have learned that I go to the toilet and I sit down. And then I void. And then I'm like, I'm done. And then I get up and I just go about my business.
Yeah.
Until you meet people that's not the case. And one of the things that you had picked up, Sherry, was, oh, you know what? Then there might be things that you're doing that you don't even know that you're doing that can kind of lead to problems with the bladder. For example, pushing to empty your bladder.
Yeah.
The number of women that come up to me and say, well, what do you mean? Don't you push a little bit at the end to get the last of the urine out? And I'm like, no, not at all. Yes, to some degree, you just want it out. You're busy. You're doing all of these things, but not when it's dysfunctional. The bladder is meant to be there to store the urine up until a certain stage so that you can empty, so you can get rid of toxins. And so it's also an indicator if you're well hydrated, if you're not hydrated. It's an indicator if there's something going on in the body. And so that's how I take a look at the bladder. When we talk about differences, so there are stark differences between the male anatomy and female anatomy. I would say that the female bladder holds on average about 300 to 500 mils, and plus or minus a few mils, but 300 to 500. So when I have women coming in, they're like, "Well, I'm holding a liter," and you see, and I'm a nurse, and I'm like, "No, that's not good at all. We don't want that." Or I can't even hold 100 milliliters, and I've had radiation in the past. Okay, so you have to take into account all of those things, because just like I had said, if you think about the bladder being an anatomical structure that can indicate to you if something's wrong in the pelvic floor. So if we take a look at the women's anatomy, we know that the urethra is only 3 to 5 centimeters long, and the urethra is that tube between your bladder and the outside world.
So I'm thinking that's maybe not even as long as my little finger.
Correct.
Yeah.
Correct. And so some people's are longer, some people are shorter, and that can be changed by surgery. So in addition to that, when we think of the sphincter, when you think of the male sphincter, which is a sphincter that either one item comes out or one item comes out, it's kind of different in women. When you think about childbirth and the proximity of the pudendal nerve and childbirth canal and injury and how that can affect the female sphincter and how that can affect the pelvic floor, you have to also take that into consideration, because men aren't giving birth either. And then you have to also...
Wouldn't we never hear the end of it if they did,
Yeah.
by the way?
Right? And so then you also have to take into consideration the distance between the urethra, the bottom of the vagina, and the anus. And in fact, I have a research study that I've just finished collecting data on, measuring in postmenopausal women with recurrent UTI compared to postmenopausal women without recurrent urinary tract infections, the distance between their urethra and the bottom of the vagina, the urethra and the anus, and the bottom of the vagina and their anus, and seeing if there's any differences. And in one of the measurements, we saw significant differences between the two groups.
So the closer your urethra is to your bottom of the vagina and the anus, the more likely you might be to be getting recurrent urinary tract infections. Is that what you mean?
We're doing the analysis now, and in the original prelim analysis that we had done for our abstract, we actually showed that difference actually was significant, and that women had shorter distances if they were postmenopausal and had recurrent urinary tract infections. And so what to do about that? There's a bunch of things that we can actually do about that. My frame of reference, and I just want to be clear when it comes to the pelvic floor, is if you're going to see me, to the best of my ability, there's something I can do. If I can't do anything, I will work with you until we hit some kind of measurable satisfaction to the best of my ability.
Yeah, that's amazing. Your story about the study that you've been doing and the distances in anatomy between the urethra and the vagina and the anus, for example, reminded me of a story I've heard you talk about, which is how you practice, which is how is different to how many others might practice, that I've actually felt quite inspired about myself, because women often don't look at that part of their anatomy.
Oh,
do
no,
they?
no. So,
and yeah, how do you approach
Did you
that?
see all of us wearing no?
Yeah.
Right? So what happens is, ladies, how can I know more about your pelvic floor? How can I know more about your fanny than I do? We can't do that. You know, your pelvic floor in your vulva is so important. And so when I'm looking at something and going, describing, the scribe is writing something down, or I'm writing in my notes, or the nurse is writing something in the notes, and I'm like saying, I'm seeing this, I'm seeing this, I'm seeing this. A long time ago, I circled back and I said that, no, that's enough. We're going to use mirrors. But I was taught to use mirrors by my predecessors. And it's a group of women that were trained by women who understood women's pelvic floors. And it was magical, because we gave a mirror to a woman, and the first thing she would say, and this is not even necessarily age dependent, I do find it in older women, but the first thing they would say is, oh, I don't want to look at that. That's ugly. I said, ugly what? You mean it's like looking at your nose or your pinky finger, right? Is your pinky finger ugly? Well, no, my pinky finger's not ugly. So I'm like, look at the vulva, and let's take a look at all the good points here.
Yeah.
And then what I found, and I promise you, I kid you not, 2 minutes into the examination, all of a sudden they're lifting their legs like this. They're trying to reach the mirror like this. They're trying to put it under to make sure that they can see, and everything changed about normalizing what the vulva and anus looks like.
That's incredible.
There's so much going on there, including that woman who you're examining suddenly feeling safe and included in the consult, which is really important.
And can we come at it from curiosity?
Yes.
Like, where does this come from that we all don't want to look
Layers,
like
and layers.
at our own body part and find it
Sexual history,
Yeah.
anti-sexual function for women, once you are done giving birth, what use are you?
Yeah.
Right?
Yeah.
And then from a sexual function standpoint, if you're not sexually functional anymore, but like, well, then what use are you? Right? And so that's an incredible thing. And I have had women who are like, I haven't looked in 10 years. And I'm like, great, we're going to look here together and we're going to go through the anatomy. And you know, they're very, very, very surprised, because say I have a 70-year-old and then I'm like, okay, do you see here? This is where your clitoral hood is. This is where the clitoris is. And they're like, where is it? I said, due to a lack of estrogen, due to aging, maybe due to lichen sclerosis, whatever the case may be, you get an architecture change.
Yeah.
And they're like, I'm sorry, what do you mean a change? Where's my fat pads, right? On the labia majora. And I said, that's a part of the aging process. But from an architectural standpoint, what can help is something like vaginal estrogen. This is why I called myself Dr. Pelvic Floor. And you can look me up as Dr. Pelvic
We'll
Floor.
Yes.
We should have started with that. Dr. Pelvic Floor. I'm going to refer to you as that now.
Dr. Pelvic Floor. You can find me on Instagram as Dr. Pelvic Floor. I'm going to do more education. But I think what shocks a lot of women is that those architectural changes. And we were talking about, you know, the vulva. And I do want to add a little bit about the urethra and the bladder as well, is we get E. coli largely from the anal cavity, right? And the GI tract, sorry. We get it from the GI tract. And there is a portion of bacteria that will sit in the distal urethra. The urinary bladder is not sterile. And this is what I've published before. The urinary bladder is not sterile. And that's okay because it has its own female urinary microbiota. And so when women start to understand externally what they look like with the mirror, then it starts to help them understand that, okay, the internal structures are also dependent on the external structures. Like we were talking about distances and stuff and how the, maybe bacterial flora can start to integrate with the urethra and inside the vagina and then also inside of the bladder. But long story short, I love mirrors.
Absolutely. Now, and so important, and I must start thinking about how to incorporate that into my own practice because that was never been part of my training. I never ever saw that used in my training.
Well, how common practice is it, I think?
Do you know that if there are others, there sounds like there are in the States where you were doing some of your training using mirrors almost routinely.
And you know what, I would say that even not, when I think of it, not everyone that was trained with me is using mirrors as well. It takes a couple extra minutes. When you think about a GP visit and you have 10 to 15 minutes, and then just even convincing someone to look with the mirror, and then the psychology around it. But once they do, it changes everything. So that first visit with me is a little bit longer so that we can establish this and everything starts to move.
Yeah.
But I think that there's a crisis in paying attention to women's pelvic floors. And this is why I'm very appreciative of this podcast, because you're not only incorporating things like endometriosis or pathology, but the fact that you want to discuss the pelvic floor and the bladder is important.
So important.
Yeah.
And just to pick up on what you were saying earlier, which I really want to have a discussion about today, is that the urine is not sterile and the bladder isn't sterile. And if you go, we've talked about, what have we talked about? Grey's Anatomy already. But my recollection from
I am more than Grey's Anatomy, just so you know.
My recollection from being a kid, I don't know, watching MASH or something, but the idea that the urine was sterile, so you could, if you
drink
had to,
it.
you could drink it. That's Bear Grylls.
Yeah, okay.
But you could almost, clean your instruments with it if you had to do a surgical procedure. But it's really only been relatively recent that I've understood that your urine, what's going on inside your bladder is not a sterile environment, and your urine isn't sterile, and your bladder has its own microbiome. Can you tell us a bit more about that? Because that would probably surprise a lot of people.
It's the coolest thing.
Yeah.
Because we know that there's a female urinary microbiome, full stop. We have mapped it as well. And that means that you can take a sample of urine and you can apply different sequencing on it. And in addition to that, if you think of the standard urine culture and the dogma that exists around that has been around since the 1950s. Okay. And it's grown under a certain standard, under a certain temperature, in a certain agar. However, we know that bacteria can live under different conditions. And in fact, to bring out some bacteria, you have to change those conditions in order to be able to see them. So if we're trying to relate that to, well, what are the causes of disruption in the urinary microbiome, or what can lead to symptoms of urinary tract infection, people having urinary tract infection, and it actually not being picked up by the standard urine culture, it's because we're not necessarily growing them under all these different conditions. And so some of the research that I did was, as a fellow, was with the female urinary microbiota. So we took the standard urine culture, and then we took the expanded urine culture. We called it EQUAC. So standard culture, expanded urine culture. And what we did was then we grew that urine over different conditions, different temperatures. And what we found was, that bacteria grew here in a patient that actually said that they had urinary tract infection symptoms. Now, the problem with that is that we grew a whole bunch of other bacteria as well. And with that whole other bunch of bacteria, they're not typically considered to be bacteria that cause urinary tract infections. So we mapped them out, and then we found pathogenic bacteria out of those.
Like those that cause disease sort of thing.
Correct.
They're nasty ones.
The nasty ones. And then we were like, we're missing a whole group of women that actually have urinary tract infections because we're not growing the urine under different cultures. That's not every woman, but we can't ignore that group of women.
So could this explain why some patients present with urinary tract infection symptoms, but yet when they're tested under standard testing, it's negative.
Yes, that is a subset of women. Full stop. 100%. That is a subset of women. That's not every woman, because you also have to think about what the pelvic floor is doing that can mimic a UTI sensation. And this is why I had said, well, what's your bladder doing? Your bladder's that strong soldier in the back that goes knock, knock, knock. Something's wrong. Knock, knock, knock. I have to urinate now. Knock, knock, knock. I'm just going to leak. And it has to do with, okay, think about what the pelvic floor is doing. If you're just going to leak and have no control, think about the pelvic floor. The pelvic floor may be hypertonic or too tight, and so it can't recruit anymore, and then you don't have any control. Or it could be in dysfunction and weak, and so as soon as you have to go, that's it, and you just leak. Or and that can contribute to urinary tract infection symptoms. I'm going to go back to that hypertonic one. If those muscles are too tight, you have pelvic pain. Even if it doesn't feel like pain, sometimes it can feel like urgency and frequency of urination. It can feel like recurrent UTI.
We see that a lot.
Right?
Yes.
And not pain, unless you do an internal vaginal myofascial exam. And I can talk about that in a moment. But sometimes at the end of the day, your bladder is an indicator as to what's going on. And I don't always want to blame the bladder. So yes.
So important.
Sometimes we're missing true UTIs. And I've published that. Sometimes it's a matter of, hey, we need to investigate the pelvic floor more.
So I think what I think would be helpful to point out is if we're talking about bladder pain, it can present in different ways, but it can certainly present like someone might think of a UTI. And most women would have had some sort of urinary tract infection over their lifetime, which is the pain urinating, which is the frequency going often, which is the urgency. And that's a very uncomfortable group of sensations. I think of bladder pain can be similar to that, but it can be ongoing, it can have peaks and troughs in terms of turning up. And it can be associated with infection, but it also can not be associated with infection.
Right.
And from the sounds, from what you describe, there might be some that could be infection that are hard to pick up as infection. But then there's probably others that are nothing to do with infection at all.
Yes.
How on earth do you sort that out when you see someone?
I'm just like, wow, there's a lot of could be's and might be's.
No wonder people feel lost.
Yeah, exactly.
And so this is why you have to take a comprehensive history. Yeah. And at the back of my mind, fighting the standard culture and fighting that dogma is not easy, because there's a whole host of bacteria that naturally grow in the bladder as well. And the issue is about antibiotic responsibility and antibiotic usage. So the worst outcome is an overuse of antibiotics, because we're already seeing multi-drug resistant bacteria that don't even, it's come up a little bit in North America, that don't even work against some of the strongest and most secretive antibiotics that we have. So, but I'm not here to scare anybody, because let's take it down to, okay, yes, there's a subset of women where it's actually a true UTI. It's just that the bacteria is not getting picked up. What percentage that is, we're working on.
Any thoughts on what that might be? Is it 50%? Is it 1%?
Not sure. My original studies indicated at some of it, and we're still working on it. And I went to Loyola University in Chicago, and I would say that that's one of the foremost teams working on the expanded urine culture and taking a look at RNA analysis and big machines to sequence bacteria inside of the bladder and differentiate from what's pathogenic, what's non-pathogenic, because we can't start saying, okay, then just give everyone an antibiotic, because that's the worst problem.
Absolutely, especially in a group where there's probably other factors going on, and then there's potentially harms of giving antibiotics for something that's not an infection.
Correct.
In terms of their own microbiome, whether that's bladder or vagina or bowel. And we're obviously dealing with some unknowns there.
So we have to clean that up a little bit more, a ton more, not just a little bit more. And it's in the process, the fact that it is actually getting done, And so, yes, some urinary tract infections are actually UTIs because that the bacteria has not been picked up. UTI sensations. And so you'll see in my notes, UTI sensation, until I get proof that this is a recurrent urinary tract infection. And how do I do that? In my office, I always do an in and out cath. And the
wow.
in and out cath to
That's a catheter. Pop it in and out just
Yep.
to get a fresh sample.
I've done thousands. It is rare for me to get a woman who's like, ouch, or like that was very, irritating. And with my staff that I've trained, they're excellent. And so we want to bypass the vulva and the vagina, because then you can pick up some background noise bacteria, and you can also pick up some background noise blood. And then I'm because I really try not to blame the bladder first, because there's other things. And if I think outside of the box, for me, it helps the patient and it helps me. So what I'll do is I'll get an in and out catheter and we'll send it off. And if that comes back negative, we do another one. Someone feels like they have a UTI, it's negative, because I have an open door policy. Feel like if UTI, come to the office. Anyone can collect it. If you do a voided sample at home, that's fine. Absolutely fine as well. But I like to be really as precise as I can, especially doing the translational research I did as a fellow. The next thing is that if that culture comes back negative, yes, in my brain, I'm like, could it be an EQUAC, expanded culture situation? Yes. Do I have EQUAC? No. If I wanted to do that, I would have to ship urine to a local, not a local center, an international center to get it read, put it on ice, etc.
And by EQUAC, I assume you're meaning one of these extra bugs that might not show up in the usual
an
scan.
expanded test.
Yeah,
exactly. And then I'm like, okay, let me not go there yet. We're getting there. So now I have a culture that's come back negative. I have another culture that's come back negative, but she's telling me I have urgency, I have frequency, I have pain with urination, etc. So I'm like, okay, I'm going to think outside of the box on this one. I published a paper that stated that dysuria, which is painful urination, and urgency and frequency are the most common symptoms for urinary tract infection. And that might sound so obvious. There's a wonderful paper that was written that showed the 7 common symptoms of a urinary tract infection. And off the top of my head, dysuria, urgency and frequency, lower abdominal pain, hematuria, which is blood in your urine, etc. That were the common 7 symptoms of UTI. The reason is some people will be like, I got a chill, and then my fingers got cold and I had a sweat. And then I'm like, okay, those are all very valid reasons, but I'm going to put all of that together to see if the pelvic floor is acting up. So the different thing that I do is an internal vaginal myofascial exam. Do you know what I mean by that? The internal vaginal myofascial exam?
I'm assuming you're examining the muscles, but tell us.
Please explain.
Correct.
Yeah.
So it's not just about speculum exam. Oh, your cervix or the apex or the deep part of the vagina looks normal. It's not just about, okay, the vulva looks appropriate for age appropriate, or it's not just about like, okay, let me give some estrogen, right? Although estrogen should be in the water. Everyone should get it. I love that stuff. Anyways, it really comes down to, I know you're saying urgency and frequency, and I know you're saying painful urination. You don't see blood in your urine. I've got 2 cultures that are negative despite you feeling like you have a urinary tract infection. Okay, let me take a single digit, my finger. Let me place it into the vagina. Let me place it on the lateral wall, the levator ani. Okay, the levator ani is a component of 3 muscles that actually make up the pelvic floor. Let me do a gentle press, and then ow.
Hit the roof?
Yes. Right. I've had women scurry up the table. I've had women go, what sharp thing did you just put in me?
Yeah.
No, nothing sharp. And that physiatrist, I want to tell you, her name's Colleen Fitzgerald. If anyone wants to look her up, her name is Colleen Fitzgerald. And she's such a pioneer when it comes to pelvic pain. That's when I said good history. Do you have back pain? Do you have hip pain? Do you have girdle pain? Let me see how you walk, because that kinetic chain published another study that said that women with low back, hip, girdle pain, if you do an internal vaginal myofascial exam and touch those muscles, a huge percentage of them have that internal myofascial pain. They won't say walking around, I have pain. It's not like that. They'll say urgency, frequency, and they'll say, oh, I sometimes feel like a sharp shooting pain.
Yeah.
And muscle can feel sharp shooting.
That's lightning vag.
Lightning vag.
we have that. Well, that's our own point terminology.
But it's funny when you say
lightning
things like that.
lightning,
It is
lightning
lightning
arse.
vag.
But you get that recognition in people's eyes.
They're like,
if we talk about
yeah.
lightning vag or lightning arse,
Yeah.
they're like, yes, that's it.
And
Because
it's
it's really hard to describe, and then we give it that term, and they're like, yes.
Yes.
Yeah.
It's sharp like a knife.
It's sharp like a,
Yes.
And all I
Stabby.
did-
stabby.
So I use a mirror And I go, look how hard I'm going to press. And what I do, can I borrow your hand actually? So what I do is, I'm just going to move this here because this is important. I'll take my finger and I'll say, I'm only going to press that much.
Yeah.
And they look at me like, that's nothing. Okay, I'll press that much into their levator ani, and they're like, you did something sharp to me. You did a 5 or 8 out of 10 pain.
Yeah, wow.
And I'm like, okay, let's treat the pelvic
And
floor.
what did that
And
feel
that's
like,
not-
Alicia?
Oh,
Like,
that
so,
would be like if you're testing your steak to work out if it's medium.
yeah. So it was just
well
that
done.
light
Just
little
that-
press.
Just
Yeah.
that little press. That's how hard you're pressing. And I do the same thing when I do examine women in my practice who come in with pelvic pain. They do. They find it really painful. And I try to say the same thing, which is, that's not supposed to hurt.
No.
Yeah.
And sometimes that can be such a light bulb moment for someone who's like, what do you mean that's not supposed to hurt? I mean, that's
what do you
hurt
mean?
for as long as I can remember. It hurts when I have sex. That's where it
Correct.
hurts.
When I have sex, exactly.
And it's
Yeah.
like, that's not supposed to hurt. That's a muscle that should be able to sit like a piece of steak on the barbecue, or maybe not on the barbecue, that might hurt, but but you know what I mean? Like it should be just a chilled out piece of something
chilled
there.
out soldier.
But then we're blaming the bladder. And so one of my
Yes.
professors used to do this all the time. She said, Tanaka, cross your legs. And I said, well, okay, I'll
needs
cross
some
my legs.
context. Yeah.
Let me give some context. So she would say, cross your legs, and I'll cross my leg. And then she's like, okay, keep on crossing your legs and press down a little bit tighter. And I'm like, okay, yeah, I will. And I'm like, I'm feeling tingly in my foot. And she said, okay, so you're feeling tingly in your foot. Press down a little bit harder. And I'm like, okay, well, the tingling is worse in my foot. And then she would say, what do you mean? Why is the tingling in your foot? Where is the injury coming from? And I'm like, well, because I crossed my legs. No, you said foot. But I'm like, well, no, because I crossed my legs. No, you're not listening to me. You said the foot is tingling, so it must be in the foot. So it must be in the bladder. 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 Uncross the pelvic floor. And then maybe that's one of the reasons as to why the bladder is acting the way it is or giving that warning signal. And so when women come and they say, it's my bladder, and then all of a sudden you say, well, okay, let me deal with your pelvic floor. They're like, you're not listening to me.
Fix my bladder.
Fix my bladder.
Yep.
My doctor told me it's something wrong with my bladder. And I'm like, okay, yeah, you're right. Let me not say that, but let's have a discussion here to not leave out your pelvic floor.
Yes. We talk about zooming out all the time, and we talk about more of a regional syndrome of all of the things that might be going on. And if we're just too focused, zoomed in on one area, like the bladder, we can go way down that place and not think about all of the other contributors.
Missing so many other parts and information that's so required to get the whole picture.
Can you talk us through how the nervous system might cause some confusion in that area? Because I think a lot of the things going on there have the same, are going through the same part of the nervous system.
Right.
But I just want to touch on before we go any further, because we've talked a lot about UTI symptoms and frequency and, urgency and, the pain, and we've talked a lot about UTI, but like how else do people present with pain or with symptoms, that like, is there anything else that we're missing? Because I find that a lot of people, especially if we're talking on bring up, my favourite topic is neurodivergence, where they're a bit unsure of what they're feeling when they're feeling it. How else do people present, and can we get a bigger picture of what this looks like and why we're thinking, is this bladder, is it UTI, and why there's even concerns around this area?
Yes. So
is that all right?
Yeah, please do.
Yeah, absolutely. So, and that's actually a really good place to start, because what it is I'm trying to narrow down as best as I can. And sometimes I can't. Sometimes it's multiple things. Sometimes it's a true UTI happening at the same time as a pelvic floor issue. So going back to what I said, which is the history, I go deep into history. Any history of abuse, any history of sexual abuse, any history of physical violence, any history of verbal abuse. How were you as a child? Any history of instrumentation as a child, kidney infections as a child. Did your mom always tell you better go to the bathroom now? Did your dad always tell you better go to the bathroom now? How are you? Any history of anxiety, any history of depression. How's your job going? Do you feel stressed at your job? Are you meeting your deadlines? And then I start getting tears. And we talk about all of that. Okay, any diagnoses that have come up. So I'm trying to think about what can trigger anything going down here. So I'm thinking about the brain. And remember, ladies, it's not in your head. It's not in your head. So I'm trying to think about but the head can affect the pelvic floor and it can affect recovery.
Yes, and I was just thinking, Laura Grace, who is a pelvic pain psychologist we've interviewed recently, was talking about it's not in your head, but there is a component of it in your nervous system.
Correct.
Which I love because we all know that this is a physical part of our system, which is absolutely valid, like everything else. And so those things do have their imprints on the nervous system, which we know. And that is not suggest that, there's no suggestion that this is not that this is minimising in any way. It's just part of a whole complex picture.
Correct.
Yes, and I think I've heard a lot of people say, I'm just going to go and do a nervous wee.
Oh, yes.
I don't know if you've heard that.
Yes. I'm just going to go because, which teaches the bladder and some behavior issues as well, but if you're coming to see me, I mean, let's be honest, as sweet as I am, maybe not, no one wants to see a urogynecologist. No one wants to be in that office, no one wants to cry. We don't want Oprah moments, and stuff like that. And I think that they're there to be like, okay, can someone get to the bottom of this? But to answer your question, and how can this manifest? So not just urgency, not just frequency, but it can also manifest as I have bloating. I feel like my belly is increasing in girth. Oh, I feel like when I'm sitting, I can't sit for too long without feeling uncomfortable. And I feel like I have to shift my position. You know what? When I urinate, I have to lean forward or I have to lean back, and I've never been operated on before. I have to push when I urinate. When I have intercourse, I have pain. Or sometimes, in addition to the urgency and the frequency, and in addition to which can be a marker for pelvic pain, actually just urgency and frequency syndrome. In addition to, I find that when I'm trying to urinate, it's actually really painful. I find that, I get my bladder full. It's so painful, but I feel better when I urinate. I find that when I empty my bowels, I feel better. I find that, if I have constipation, it makes everything work. I find that when I have my period, I feel like everything's worse. I find that if I'm stressed out or I have an anxious moment, everything feels worse. I feel when my back pain is aggravated, I feel like my pelvic floor, I feel sharp shooting in my vagina, but my hip, when my hip hurts as well, and I'm not walking as well. So it can manifest as, yes, what I've said before, urgency, frequency, dyspareunia, which is painful sex, as well as not being able to get your urine out, and also bowel problems. But when we're talking now with that nervous connection, like I said, and I always say this to GPs, women that have low back, hip, girdle, discomfort, pain, bulging discs, etc., a high percentage, over 90% of them, if you check their internal vaginal myofascial exam, at least according to what I had found, have some form of pelvic pain when you touch those muscles. Mm-hmm. In addition to weakness of the pelvic floor, in addition to nerve damage after having childbirth, in addition to nerve damage with degenerative disc disease or bulging discs, in addition to scoliosis or arthritis, osteoarthritis. The list can go on and on and on as to what can affect it. In addition to endometriosis, right? Endometriosis is not necessarily on large scale studies, endometriotic implants on the levator ani. No, it is more about that pain. It's in the nervous system, and it's that pain response, and it's those prostaglandins, and it's the irritative process that comes around with menses. Multiple instrumentations. So if you're going every month because you have heavy bleeding, you have fibroids, you feel pressure in I can go on. I can go on.
There's a lot.
I can go on.
It's so complex, isn't it? And I think sometimes, and I admit this from time to time, that I look at some of the endometriosis forums that are around on social media, and it's common that someone will pipe up and say, I must have a new endometriosis lesion on my bladder because I'm getting these symptoms. Yes. And I always think, well, you might, but you also might have another sort of complex manifestation of all of these other things going on. Is it your bowel? Is it your pelvic floor? Is it an infection? Is it a sort of a low grade infection? Is it a nervous system flared up? Is it to do with the inflammation and everything else? Like it's as Matthew Leonardi, who you may know, the gynecologist, Canadian gynecologist, don't think about things so simply. This is a complex beast, which is where it's helpful to have someone who is adequately across this to work with you to start sort of piecing things together. Otherwise, you just end up at a dead end somewhere, and you don't get an answer to your problems.
Yeah, and we don't want to put that Band-Aid on.
Yes,
exactly.
And you know what? And then there's also some people that might have true interstitial cystitis.
Yes.
I was just going to ask about that.
Because, I admitted to Cherie before the podcast started today is interstitial cystitis did not come up in my training.
Mm-hmm.
And I would have been a GP trainee. I would have been well into working as a doctor before I even came across the term of interstitial cystitis.
Yep.
And had to look up on it. This is obviously quite some time ago now, but take us through that. What's your sort of take on that as a urogynecologist? So
there was a period of time, from what I can see, that anyone who came with any bladder problem was labeled to have interstitial cystitis. And so urogynecologist did so many cystoscopies, and we're like, okay, wait a second. We're not necessarily seeing the markers for IC, interstitial cystitis. And
I see everything as interstitial cystitis. Yes.
And so cystitis, cyst, bladder, cystitis, and itis, inflammation, and, something happening inside of the bladder. So,
And Tanaka, what is a cystoscopy?
Cystoscopy is where we take a camera, we go through the urethra and look inside your bladder. It's a very nice tool.
And is that common for, like, when would you do that with somebody?
Not necessarily initially, because there's a theory that, at least from a female urinary microbiota standpoint, that instrumentation can also affect your FUM temporarily.
Yeah.
FUM, female urinary microbiota.
I thought you meant farm, like a farm of little bugs.
You always go there, don't you? Soups and farms and barnyards.
But you know what? Even, for example, antibiotics can affect the FUM. Yeah. And what happens is that at some point then that FUM can come right on back, right? Because you need a certain number of good bacteria, right? And this is why we like estrogen so much, because it changes the pH in the vagina and get that good bacteria. But with the cystoscopy, what you're looking for is for any pathology and any issues, when I say pathology, on the bladder lining. Now, I can't see beyond the urothelium, the bladder lining, the urothelium. I can't see beyond that. But we're looking for cancerous lumps, masses. We're looking for Hunner's lesions, those lesions of scarring and irritation and inflammation that you can sometimes see in patients with interstitial cystitis. There's another thing that we used to look at all the time, which is something called glomerulations. I said it, glomerulations. So glomerulations are, you feel someone's bladder up and you don't necessarily see anything. But as you start to empty a little bit, you start to see all these petechiae of blood kind of cascading. And so you had to have it in certain quadrants, or in a certain number of quadrants, in order to get that definition.
Like actual bleeding?
You'll see actual bleeding.
Okay.
It's actually quite shocking when you see it. And so you'll have someone presenting with bladder pain. When their bladder gets full, they feel pain, in addition to other stuff that they might have ongoing with their pelvic floor. But when you see a Hunner's lesion, when you see true IC, that's tough. That's tricky. And I go, okay, we'll work together with this. I won't let you go. This might be a little bit more lifelong. And this is why when I tell patients, I'm like, I'm going to take away that definition of IC, because if you do have true IC, well, it's a little bit of a trickier situation. However, we can work through it and we can get you some treatment. That's why I say I didn't see anything in the bladder, which is good, but doesn't mean that there's nothing going on.
Yeah. That's right. That's only what we can see. Yeah. I do sometimes see people will bring their pictures in of endometriosis surgery and also cystoscopy. And I'll see a bladder which looks really angry. It looks really red and cranky. When do you see that? Is that mainly in IC? Can you see that in just an overall cranky bladder? Is there something else going on there?
So the tricky thing is that what's the definition of interstitial cystitis? And so they've actually merged terminology, interstitial cystitis / bladder pain syndrome.
Yeah.
Because they understand that you don't necessarily have to see things like glomerulations or vice versa. So sometimes you can see glomerulations in patients who are like, I've never had a problem in my life. I don't know what you're talking about. I feel so happy. You're just incidentally doing a cystoscopy for something else, right? And that's the petechial hemorrhages that I'm talking about. And so glomerulations, it's a tricky thing to incorporate into that definition. However, Hunner's lesions, you'll see the scarred central white with the flame of red lesion, angry looking and scarring and intolerance to just filling the bladder in general, combined with that pain and urgency and frequency, etc. That is a little bit more clear, but not everyone necessarily has Hunner's lesions. So then it leaves an in-between of, are we missing a group of people because we're not, there's a layer in between the urothelium, that bladder, that layer that you can see, and then the underlying layers that, okay, maybe those underlying layers are irritated and there's something going on. And this is why we give things, injections and things like that to kind of help those layers.
What are your thoughts on what's actually driving something like interstitial cystitis, especially when you can see that visible inflammation and scarring and things?
Do we
know
like autoimmune?
Yeah. Well, is it autoimmune, or is it mast cells, or any thoughts on what's going on there?
You pretty much said what we're thinking.
Okay.
You know, you pretty much, long story short, we don't know, and we're doing more research into it. Now, we do know a lot. We know about that GAG, that gag layer. Have you heard about that gag layer
I
before?
feel like completely, I don't know anything, actually. Like, it's the thing. It doesn't matter how much you learn in this, you keep learning things. So, no, gags, I don't know about.
Yes, and so there's a layer. So you have that urothelium. That means that you take your camera, you go into the bladder, and you can see this layer. And it can look normal to you, or you can, if you see Hunner's lesions, okay, I see. That makes it easier. If you see glomerulations in the petechial hemorrhage, you're like, I don't know. Like, it doesn't necessarily fit in the like, for example, certain definitions just don't include glomerulations. Okay, they used to in the past. Or then you're like, okay, but I can't see beyond the urothelium, and I'm going based on the patient telling me this, and then a trial of medications to try to help ease that layer that you can't see. So if they're feeling better after some of those bladder treatments and installations, okay, all right, sure. But if not, can't discount the pelvic floor.
So we knew we'd want to talk to you all afternoon.
I know.
Let's think about someone who has a lot of bladder pain, who I see every day, people with lots of bladder pain. If I've done my best to be ruling out any sort of infection that I can find, the next thing I want to think about is, what are some simple lifestyle type things that might either aggravate or help with the bladder pain in terms of symptoms?
Yes.
Like things that might be in someone's diet and trying to modify those things. What are your sort of go-to for that bladder pain in terms of starting some lifestyle changes and lifestyle management?
Yeah, that's an excellent question, because we have to take into account, okay, it's very important for me to say this. You have to take into account BMI. And not just BMI, and not just BMI when I'm like the BMI calculation. I'm talking about weight, because weight can has effects on the pelvic floor. Yeah. Then you also take into account what you ingest, things like chocolates, things like citrus, things like alcohol, things like smoking, anything that can ingest that can be irritative. I go to women, I'm like, listen, I'm not going to take away your wine. I probably make this worse, by taking away your wine. But also at the same time, let's see how much wine you are drinking.
Yeah.
Right. Let's see how much coffee you are drinking. Yep. So I'm like, let's just go on a trial. Can you come off wine and coffee for a week, and let's just see what happens? And I don't have as much urgency and frequency.
Helps.
I don't have as much irritation here. And I'm like, so now you know. So you have the power that it's going to be a tough night if you go ahead and do this.
Yes.
Right?
So bladder irritants, alcohol,
citrus,
caffeine, carbonated drinks,
smoking.
In terms of the carbonated drinks, sometimes patients I talk to, that surprises them. And when I say, okay, carbonated drinks, how much are you drinking? It might be Soda Stream, might be soda water, might be Coke, Diet Coke. And then people go, oh, actually, that's my thing. I drink 4 or 5 cans a day, or 2 or 3. And that surprises people, the carbonated drinks.
Do I have an exact pathophysiological link as to how it affects? No. With citrus, I have an idea. Right, because you're going to have to filter some of that out, and
the acid
it's broken down into. Is it maybe the acid of it? Maybe it is. It's kind of like the FODMAP diet, very good to do for some people, but do we exactly know how it works? So what I do want to say is that we don't also want to miss out on what the effect on the GI tract. GI tract constipation, GI tract sensitivity, GI tract bloating, GI tract irritation, diverticulitis, diverticulosis, etc. also has impacts on the pelvic floor, and also has impact on bladder symptoms. So it's not just one system. And so...
Yes, we come back to the swinging balls of the Newton's cradle.
The Newton's cradle, not just random swinging balls.
And not random swinging balls.
Not random swinging balls.
No.
It's just that perpetual motion.
Yes, Newton's cradle balls. And I imagine that menstrual cycling is going to be part of that as well, because someone's bad period is going to play into that.
You get a prostaglandin increase. And you know what, the way I think of prostaglandin, it's like hot sauce to the pelvic floor. And then you have...
That's a T-shirt.
Right?
Yes, that is a T-shirt. We need what's that, red cap or something? No, not red cap. Red bubble
balloon.
Yeah. Can you imagine once a month just taking out, a bottle of hot sauce and just pouring it into the pelvic floor like this and being like, okay, now sizzle. And then you have endometriotic implants in there in addition to that, or you have adenomyosis, or you have just long menses, or you just have a regular menses, by all accounts, 3 to 5 days or 3 to 7 days, and it still activates the pelvic floor and it still activates and irritates the bladder and the gut.
Why does it do that? Is it that connection with the pelvic floor? So why are we having these like bowel and other issues that, how do you know why it's impacting the bladder?
So there's direct things that can impact the bladder. For example, if you have an endometriotic implant on the bladder wall, that's a direct. And then there's the indirect that I talk to patients a lot about, what the pelvic floor is being irritated. So give me your finger. Just go like this for me, like that. So if this is your urethra, right over here, and then I'm the pelvic floor, I'm starting to tighten. Does that feel comfortable?
Yeah, no,
I'm starting to tighten.
That's very uncomfortable.
So that's
and I'm starting to
pulling
tighten.
on Cherie's finger. I'm hoping you're not going to fart.
Yeah.
Pull my finger, joke.
And it's not just pulling, it's also squeezing.
It is squeezing,
The pelvic floor pulling on and squeezing on the urethra.
Hypertonic pelvic floor. Now let's take a look at your finger. Look how blanched it was.
Yeah.
So I affected blood circulation, I affected nerves because I became hypertonic. What made me hypertonic? The menses blew up. What made me hypertonic? I was just sexually assaulted. What made me hypertonic? My depression kicked in.
Yeah.
What made me hypertonic? My anxiety. My boss just yelled at me. What made me hypertonic? I got a kidney stone. It's coming down here. So multifactorial impact that can be indirect onto the pelvic floor.
Or I just got my period and I've had the prostaglandin hit, which is the hot sauce on the pelvic floor.
We're going to be using that.
And it's not like on the muscle. Like I said, I mean, I don't know if I've ever read a study of there being endometriotic implants in the levator, and there probably are. But what I'm saying is that it's that indirect effect, and that's strong enough. That's it. That's enough. You're remembering something that happened to you when you were 6. You're remembering, oh, here we come. Oh, Dr. Dune, Tanaka Dune's doing another pelvic floor exam, and the pelvic muscles tighten up. Right. And so anything can affect it. We as physicians can affect the pelvic floor.
I just want to ask quickly about the microbiome as well, which is, I just find that fascinating. Like, is there anything we can do to assist that? Is it like, they talk about the, probiotics and prebiotics of the bowel. Like, what can we do for bladder microbiome?
So if you think so let me add to the explanation of the urinary microbiome. So if you could take a look at all the bacteria in the urinary bladder, in a bladder that does not, for example, have a urinary tract infection, you'll see that there is lactobacillus, that good bacteria. If you see in the vagina, lactobacillus. And so there's going to be a component of E. coli that the bacteria that frequently causes urinary tract infections, by the way, is E. coli.
Creeps around the corner.
Yes. So it's in the anal area, it's in the vagina, and a little bit of it is in the urethra. And it just sits there and it just lives there. If you break the balance, you have a rise in pH, and then you have a change in vaginal flora because of menopause, and that you're not using any estrogen, then all your barrier inside the vagina is then affecting what happens inside the urethra and the pelvic floor. Inside your urethra and the bladder. So if you get anything that changes that can cause a disruption of the natural balance, then you're susceptible to the urinary tract infection, because the bacteria in the bladder are there overall to protect. The female urinary microbiota is protective. And so we know that it changes by giving bladder medications for incontinence. We know that it changes, if you have a drop in if you have a rise in your pH, because your pH increases when you get to menopause, and then all of a sudden its protective effect is not there. Does that kind of answer the question a little bit?
Yeah, a little bit.
Yeah.
Is there anything else that we can, like, anything else you can actually do? Like I heard, how like they say, I don't know, I'm probably making this up, but like, cranberries are good for kidneys and whatever. Is there like something you can like ingest, or, you talked about estrogen, like, I'm just thinking for patients who are like, well, what can I do if things are disrupted? Besides pelvic floor, obviously, which is super important, and I'm just so excited.
And the rest of the swinging balls?
The rest of the swinging balls.
The bowel,
yeah. But, like I think we all want that little panacea of like, oh, well, let's take, we talk to colorectal surgeons about, the importance of probiotics and PHGG and, stool tougheners and stuff like that. But it's like, is there anything that we can do for the bladder in that sense?
I think we're so close and not quite there yet, because people have already made lactobacilli capsules you can place in the vagina. And they've tried lactobacilli treatments in other areas as well. Like, for example, if someone has C. diff and then they get the fecal transplant to put a normal fecal transplant into someone who doesn't have the normal microbiome in their gut, and then boom, they're better. All of that research is getting done. Is there something right now on the counter that you can get to restore your flora? Over the counter, sure, yes, it's good to take a probiotic overall, and there are vaginal probiotics that you can take. But if you're considering in the postmenopausal state, decreasing that pH to a more acidic pH, and then in addition to that, restoring the flora inside of the vagina with vaginal estrogen, I cannot emphasize how important that is. To me, that is the number one probiotic. It's not a probiotic, by the way, but that is the most important thing that you can do from a postmenopausal state so that you can prevent urinary tract infections.
Certainly helps to recover their microbiome through dropping the pH and so forth.
And also decrease changes in architecture. It'll not restore what you lost, but at least the rate of loss can be slowed down.
And get a mirror. Should everyone get a mirror, or should it be guided?
Everyone.
Could you just go home and have a look?
Everyone should go and have
a curiosity look, and then,
Some
take your questions to you.
20 years, 30 years.
Or ever. I reckon there'd be people that haven't looked ever.
Yeah.
Tanaka, just to sort of round things up.
I know, I don't want to let her go.
No, I can tell.
Alicia's like, shut up, Sheree.
No, definitely not.
She's giving me the wind up.
Oh, no. Tanaka, just to wind things up, there will be someone listening at home who is stuck in the tornado of pelvic pain, and particularly bladder pain, who is lost, who might have had multiple GP visits, they might have had multiple emergency department visits, they might have seen a gynecologist, they might have seen a naturopath, they might have, they probably, often haven't seen a pelvic physio, which would probably be a good thing. What would you like to leave them with in terms of where to start and where to go to try to start helping things get better?
So I'm so proud of this person that their bladder keeps talking to them to be like, there's something wrong. There's something wrong. There's something wrong. There's something wrong. And so they've seen the GP. They've gotten the images. They've gone to the emergency department. They're doing the best that they can. The next thing you can do is see your urogynecologist. And not only that, see my best friend, the pelvic floor physiotherapist.
They're our best friends. Don't we love them?
Yes. Aren't they wonderful?
They're incredible.
That is my best friend. See the pelvic floor physiotherapist, because the assessment of the pelvic floor can be done there as well. And then you can know, if it hurts, hey, we have something to work with. And then, of course, the GP would have checked the urine. The GP is my best friend as well. And if the urine has been checked, the images have been done, the renal ultrasound, the pelvic ultrasound, the CT scan has been done. Now the pelvic floor is checked. All of a sudden, if you come to the urogynecologist, okay, then we can do some interventions.
Associate Professor Tanaka Dune, thank you so much for your time and for sharing your wisdom. I can't wait to hear what you do next as you continue to set up your practice as the pelvic
double
Dr.
board
Pelvic
certified. Dr. Pelvic Floor.
Dr. Pelvic Floor, thank you. We'll pop that in the show notes. Thank you so much. All the best with your upcoming adventures.
Thank you. Thank you so much.
See you back on here soon, I'm sure.
Thank you both.